let us, in this engagement, bring everyone together as we offer this critical service of palliative care to your people, all for your greater glory. We ask this through Christ our Lord. Amen. Thank you.
Once again, good morning. If you can hear me and see me, lift your right hand. If you can only see me, lift your left. Okay, at least everybody can see and hear me. Good morning, my name is John Weru. I'm the chairperson of the Kenya Hospices and Palliative Care Association. I want to once again welcome you, not to Kisumu, but to Kisumu that respect people living with palliative care needs. Okay? And a Kisumu that has a lot of environmental friendliness. And a Kisumu that is very clean. Very? We've just been here a few hours and we realize that we have a city that is clean. Okay? But as we start, it's also good to appreciate all of you for coming and attending this 6th Kenya Hospices and Palliative Care Association after a big hiatus that was promoted by a lot of issues that were beyond our control. So in the next 2 days, 3 days starting yesterday, 4 days starting before yesterday, we're going to share a lot. So feel welcome with a lot of love, a lot of hope, a lot of friendliness, and a lot of looking forward to the days to come. So welcome once again to this conference, and I wish and hope that we are going to share a lot from each and everyone. And as we continue interacting, please, let's network. Because if there is a field that cuts across all healthcare activities, that cuts across from pediatrics to geriatrics, that cuts across all the fields of medical practice, that cuts across all the policies and guidelines that we talk about, is the field of palliative care. So let's network and welcome once again. Thank you.
Good morning. I'm happy to be here this morning, and we have papers to present this morning, and for the interest of time, each speaker will have 20 minutes. So within your 20 minutes, make sure that you give us what you want to give us, and also we'll have a plenary for the questions after the presentation. So this morning, I have the privilege to welcome our first presenter, Professor Emmanuel Lurinka. I'm waiting for his bio to be somewhere. He is very passionate about palliative care. He is the CEO of Kehpca, and those who normally ask for small grants, it is this gentleman standing before me that you have to appreciate, that you normally get your grants to do your projects in wherever county you are. Otherwise, with those many remarks, welcome, karibu sana.
Asante. Good morning, everybody. Not yet professor, but I'm on the way there. Maybe when I retire in the next 2 years, hopefully, I'll be hitting the retirement age, and I have no intention of extending the goalposts. Yeah, so I'm really happy to be here. I hope my presentation has gone on the board. And Okay, they are still sorting out the technology, but I didn't come alone from the African Palliative Care Association. I have my colleague, Dr. Eve Namisango. I don't know whether she's here. Just so that you see her. She's the person in charge of research and programs, and the small grants that my sister talked about lie exactly under her docket, and we encourage you to apply for those grants together with the scholarships. So my task this morning is about discussing palliative care in the context of universal health coverage and primary health care. And it's important that we understand these three concepts. What is palliative care? What is universal health coverage? And what is primary health care? And therefore, how do we domicile palliative care in those contexts? So we'll go and look at those three aspects, and then we'll look at the countries where this has been done, certain aspects of this has been done, so that we can then know where to get best practices. For those who are not traditionally from the palliative care fraternity, palliative care is an approach that improves the quality of life of patients. And when we say patients, we mean children and adults and their families who are facing problems associated with life-threatening illness. Palliative care prevents and relieves suffering through the early identification, correct assessment and treatment of pain and other symptoms, and whether physical, psychosocial, or spiritual. So we look at the person holistically. And this definition is by WHO, and it still holds. Universal health coverage, on the other hand, I was very delighted to know that the boss from the NHIF is here. And I think Kenya is leading in pushing us within East Africa towards that. Universal health coverage means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. That at the time you need the services, you are not asked for money from your pocket at the time you need that service, wherever you go. So that's the ideal of universal health coverage. It covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. You know, my background is in family medicine, and in family medicine we say it's the care of the skin and its contents from the cradle to the grave. And palliative care adds, and even beyond the grave, because we must handle the bereavement that comes with it. And therefore, universal health coverage must cover the skin and its contents from the cradle to the grave. And so, as we discuss inclusion of palliative care in UHC plans, we need to know exactly what we want. Now, how about primary health care? Those of us who went to either nursing school or medical school or allied health schools in the 80s, you remember that this was almost something that you had to cram. What was primary health care? What were the elements of primary health care? Where was it conceived? And the word alma mater became very common in our understanding of primary health care. So primary health care is a whole of society approach to health that aims at ensuring the highest possible level of health and well-being, and their equitable distribution by focusing on people's needs and as early as possible along the continuum from health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as feasible to people's everyday environment. So the whole idea of how far are you from the service that you need became very important within the context of primary health care. Not setting up ivory towers where patients are supposed to go, but we are supposed to reach the patients nearest to where they live. Primary health care is essential to a person for leading sound health throughout the life course. This includes, again, the physical, mental, and social well-being of all people at all times. Again, it should cover health promotion, disease prevention, treatment, rehabilitation, and palliative care. So you see the three concepts: palliative care, universal health coverage, and then primary health care, and the various aspects that should be planned for and delivered. Primary health care has pillars. There is an issue of universality in access, which you also find in the concept of universal health coverage. And this means that everyone, regardless of their socio-economic status, gender, ethnicity, should have access to essential health service. Of course, we know it includes things like vaccinations, maternal and child health care, family planning, and treatment of common diseases. And the beauty with primary health care is that it helps you to understand, to plan for the things that are common in the environment where your patients are based. And so you don't just say, oh, in America they do this, so in Kenya we'll do this. In Kisumu they do this, so in Kisii we'll do this. You focus on the environment where your patients are. In this context, universal access is crucial because it ensures that everyone has access to basic health services, regardless of their ability to pay. Again, that should be underlined. Regardless of their ability to pay. We are being invaded by the desire for health services to be paid for. We are building private hospitals, which is good, but we must set up a mechanism that does not put patients in a situation where they have to pay at the point when they need the services. And primary health care focuses on that very well. There is also the pillar of health promotion, which aims to improve the health of individuals and communities by promoting healthy behaviors and lifestyles. This includes health education, proper nutrition, and encouraging regular physical exercise. I want to commend the team at Kehpca for putting us in a hotel some distance away, that we are able to walk in the morning to the venue and walk back, so that we don't go back with the fat that we acquire from here during the conference. So that is very important. And so you really did it the primary health care way by doing health promotion. And health promotion is important because it helps to prevent the chronic diseases, which in the end cause us to need palliative care. And that's again something very important within the primary health care context. So this pillar is very important. According to a report by WHO, in sub-Saharan Africa, 37% of the deaths were due to non-communicable diseases. And therefore, this becomes very important. There was another cohort of 7 countries in Africa where they found that 50 to 88% of deaths were due to non-communicable diseases. So as we provide palliative care, we need to understand this context. So that we do not just visit homes to see our patients, but also to make sure that the message around health promotion and prevention of these diseases is done. I'll need the timekeeper to be showing me the time so that I don't overshoot. The third pillar is disease prevention and control. The third pillar in primary health care is disease prevention and control. It involves identifying and preventing the spread of communicable diseases such as tuberculosis, malaria, and HIV/AIDS, but also some of the diseases that are endemic. So if a certain place has some endemic diseases, then those should also be prevented. Do we have some endemic diseases in Kisumu? Do we? We don't. Okay. So disease prevention and control are critical because they can help to reduce the disease burden in a community and improving overall health outcomes. The fourth and last pillar is community participation. And that is very important. It involves planning, implementation, and evaluation of primary health care services. Community participation can also help ensure that the services are tailored to the specific needs of that community. And therefore, you offer targeted services. It also helps to build trust between the healthcare providers and the community. So the time of planning for the community without their involvement is out with primary health care. So those four pillars are important. So we started with universal health coverage and then primary health care, and the two speak to each other, and especially on some critical issues like ability to pay and the place where you offer the service. And that's also very important in the context of palliative care. So, what are the key components of primary health care? Nursing, allied health work, and medical schools may have drifted a bit from the ideals of primary health care, but many countries now are moving back to making sure that primary health care is part of the training and the service. So the key components are health education, as we've said, proper nutrition, prevention and control of locally endemic diseases, and provision of essential medicines. In the old language, it's essential drugs. Provision of essential medicines. And the World Health Organization built a list of essential medicines. And within that list, we have the essential medicines list in the context of primary health care, but also in the context of palliative care. And it's important for us to understand those four components, because then it helps us to know how to integrate palliative care within the primary health care context. This picture was taken in one of the hospitals in eastern Uganda, where we were talking about integration of palliative care into their services. Now, approaches to palliative care inclusion in UHC and PHC. Universal health coverage has a central place in achieving the SDGs by 2030, and it's a major target, which is 3.8 under SDG 3, ensuring healthy lives and promote well-being for all at all ages. The WHO has given us a definition of UHC, and as I mentioned, palliative care is included. Therefore, UHC brings hope for better health and the protection of the poorest at every stage of their lives and at every stage of their illness. So it is important for us to know. That picture was taken in Spain while we were discussing the then new African Palliative Care Atlas with partners from various places. So the African Palliative Care Association having received the Lancet Commission on Pain Medications and Palliative Care, worked with stakeholders to develop an essential palliative care package for inclusion in universal health coverage. And this package has 4 components. The first component is essential palliative care medicines. So there is a list of essential palliative care medicines, including the controlled medicines like morphine, which must be available at no cost to the patients. I want to mention morphine because in most countries, that's what is difficult to get because of the myths, the control, and failure to get people who can prescribe it. So the first one is the essential medicines. That list is in there. The second package, essential equipment, patient supportive devices, technologies, and supplies. You have pressure-reducing mattresses, you have NG drainage and feeding tubes, urinary catheters, opioid lock boxes. This package was costed. In fact, the costing happened in Kenya. Kehpca was a lead on that. So, and then you have other aspects like radiotherapy for patients who need palliative care who need radiotherapy as a palliative modality. And then, of course, other technologies like mobile phone platforms that are used in stock control and management and patient health work interaction. The third one is human resource, which must be multidisciplinary. You need them in the package. And then the last one is the psychosocial interventions, which include spiritual care, legal aid, social support, such as subsidies and others. Yesterday we were talking about taxes for persons with disability and issues around public transport, nutrition support, and drawing from the various social support services to make sure that your patients have all they need. So as also a cross-cutting action to revoke taxes on medical supplies and equipment for palliative care as may be needed. So why the essential palliative care package for inclusion in UHC? To provide readily available guidance so that people can do what they're supposed to do, as well as provide a tool for government to plan and budget. So when your national health insurance is looking at how to include palliative care in the NHIF, they have a package ready, prepared, developed in Africa, piloted in Kenya, and therefore making it easier for your patients to get the services. So at the national level, what are the model countries? I'm about to stop. I have about 1 minute. The first one is Seychelles. That's a picture I took when I visited the 3 islands of Seychelles and looking at what they have at the different levels of the healthcare system. And they had all the medicines that patients need for palliative care. They also have the highest bed per 100,000, hospice beds per 100,000 of population. They have six beds, and their population is less than 100,000. So if you are there, you are more likely to have access to a palliative care bed compared to other countries. I don't know how many palliative care beds we have in Kenya. David, you will help me. Yes. And it's integrated in their entire system. What they lack is access to radiotherapy, and they transfer their patients to other countries. The second one is Botswana. They have the whole range of services, including provision of things like diapers. The government pays for them, and the food basket for patients who are in need of palliative care. It's delivered at the patient's home. Radiotherapy is not available in the government service, but government pays for it in the private service, and patients get it. So that's how far they move. So these are very good examples for us. The last one is not the complete package. I mentioned Uganda only for medicines. In Uganda, if you need oral liquid morphine, whether you're in a private hospital or a government hospital, you get it free, irrespective. Government pays for it, to works with Hospice Africa Uganda to manufacture it, and every patient who needs it gets it free, and they have doubled that with equipping nurses to prescribe the oral liquid morphine. So those are three examples that we pick from the Africa context. So as a way forward, we need to increase advocacy to include palliative care in national UHC plans, in national health insurance plans and implementation. Palliative care must be in. Secondly, we need to work on the policy frameworks to reflect the new reality, the financing mechanisms, the human resource planning, medicine service delivery plans, and in the collection of data within the healthcare system. This picture was taken in DRC with the Ministry of Health, University of Kinshasa, and the Cancer Directorate, as well as civil society, as we are planning their better access to controlled medicines. You can find the rest of the references indicated there. Thank you very much.
Thank you very much for keeping it short and clear. And I think this has come handy as we launched the PNC, the Primary Care Networking. So with this in mind, now when we go back to our countries, we know what to plan so that we can include the palliative care package in our counties for better planning. Can we give our presenter a good clap? Yes. Perfect. Now we'll have the next presenter. We'll have all the presentations. Then the question plenary will come later so that we don't take so much time. We'll move to our next presenter, who will be Dr. Sally Hull. She's a trustee of the Kenya Hospice Care Kenya, a charity which raises funds in the UK to support development of palliative care organizations in Kenya. For over 30 years, she worked as a family doctor, and she's also, she taught the academic programs for the MC programs-led research. She has a family in Kenya, and when she joined the board in the year 2005, she became a chair up to 2016. Over the years, she visited many hospices to see and support their inspiring work. Now she's retired but not tired, and that is why she's with us today to share the experiences she has had over these years. In her presentation today, she will talk about collaboration for palliative care, initiatives in Kenya, hospice, and with that, I think we can give her the opportunity so that we can hear more from her. So can we clap for her as she comes until she talks, until she talks. So before you talk, they'll not stop clapping.
Thank you so much. Right. I'm enjoying the clapping. Thank you. Thank you so much for that introduction. Yes, so my name's Sally Hull, and I've been a GP in the NHS in London for 30 years. And I was absolutely delighted by the last speaker who said that my job was all about caring for the skin and its contents, because this idea of being holistic is so important to primary care. Anyway, I'm also the chair of trustees of Hospice Care Kenya, and as was said, this is a charity based in the UK that raises funds to support palliative care throughout Kenya. And thank you so much to the organising committee and everyone who's worked on this to make this conference happen once again. So last time we were here was 5 years ago at your Nairobi conference, back in 2018. And over on the left there, you can see me looking a little bit younger. But you can also see Dr. Mike Hughes here. who's also a trustee of Hospice Care Kenya, and he's a specialist in palliative care in the UK. But he also once worked at the Nairobi hospice about the same time as some very illustrious doctors you have, Dr. Zippy, who was nearly contemporary with him. And he is there describing our core grant-giving program, which still continues. And what we do is we provide funds to support training for nurses and for community health workers, funding for support for new projects and outreach to areas and to populations without hospice access. We also provide funding for some essential medicines and for community advocacy for palliative care. Now, HCK has been supporting you for over 30 years now, and it's an enormous privilege to see how palliative care has changed and developed over that time. And I think this is very well illustrated by the story of Nairobi Hospice. HCK was actually founded in 1990 to support Nairobi Hospice. And at that time, of course, it was the only hospice in the whole of Kenya. And it started in that little shed you can see on the top left, tiny shed with a blue door. And over time, that the hospice has occupied a lot of different buildings. And when we came in 2018, we were absolutely delighted to be able to take that photograph with the scaffolding up as the new hospice was being built in what had previously been a car park. And look at it now in that bottom right picture. A confident, spacious, purpose-built hospice. And now when I look at the Kehpca website, there are 106 providers of palliative care. Your community has grown so large. This is such a success story. Yeah, give it a clap. And back in the UK, we need to run to catch up with what you're doing. So in order to do that running, we have updated our strategy, our vision for the future, which I want to share with you. Our strategy underlines our priorities for funding and has three main themes. First of all, it's partnership, which continues to support you in providing for local needs. Secondly, is empowerment, training those who provide care, but also training to provide skills for local units to become really well managed and self-sustaining. And thirdly, advancement, extending hospice to new areas of the country and to populations with poor access to care. And what I want to do is to tell you a little bit about how we're putting these three themes into practice through some projects that we've developed with partners in Kenya. So first of all, partnership. So this project explored whether using the Kehpca palliative care outcome scale was useful in routine care. And that meant really, was it useful either for the patients, for carers, or for the staff themselves to identify where the gaps in care were? And we tried this out in 3 hospices across Kenya and tested it on 90 patients and their carers, over half of whom the patients had a cancer diagnosis. And the results showed that across all the domains of the Kehpca outcome score, there was improvement in scores for both patients who are shown on the left, they have a longer survey, and carers on the right. The blue columns are the first score, which were taken, the survey was taken before palliative care started. The orange columns are the second score after at least a month of palliative care. and in this context, lower scores show improvement. So you can see there was, and the staff could see, that there was improvement in scores, particularly amongst patients for worry about their condition and for pain. So that's really positive, and I think I was really delighted to hear that CEA, who was one of our sites, continues to use the outcome score in routine care. And you can see more details about this project on our poster, which is stuck to one of the windows down the corridor. Our second theme is empowerment. And this year we ran safeguarding training for hospices. Now, safeguarding makes sure that your organisation is run in such a way that it actively prevents harm, bullying, abuse or neglect. And it's also about making sure that you're ready to respond rapidly and effectively if any problems should emerge. And we ran a very successful workshop with delegates from 11 hospices, and we also provided materials for hospices to develop their own policies around safeguarding. And our third theme is about advancement. And we've just started a project on developing palliative care for children. And our first aim is to engage families, along with community, religious leaders and teachers, to help them understand what paediatric palliative care can offer and actively begin to build the demand for this kind of palliative care. We also want to upskill doctors on child pain management and CHVs on home-based paediatric palliative care and family support. So that's our three themes. And so finally, if you apply for a grant from Hospice Care Kenya, what do we need from you? Well, first of all, I'd say we'd like to see some bold new projects. Think outside the standard. Come and talk to us if you are concerned that it may not fall within our remit, but if you don't try, you'll not get one. So we want bold new projects, and once you've decided on your project, we want a very clear description of what you plan to do. And associated with that, a realistic budget. And I concentrate on the word realistic. And those of you who've had a grant from us will know that we ask for monitoring reports every 6 months through a project. And what we want you to do is to tell us about your project and tell us about the impact that it's had on your patients and carers and on the staff. And we want you to tell us about that in numbers and in pictures, whether photographs, but also videos that we can put on social media and in stories. And why do we need that? We need that because we need it to put in our newsletter, which we circulate to all our funders in order to raise money in the UK. And our donors, they do ask us questions. They particularly ask about the impact of where their money is going, and they ask about the long-term sustainability of your projects. But they also ask about financial governance, and they ask about safeguarding policies, which is why we have been setting up those kind of seminars. So finally, do come and talk to us about new projects. There are 2 other members of Hospice Care Kenya here. Pauline Everett, there she is, she's waving her hand. Wave your hand again or stand up. So Pauline is the director of Hospice Care Kenya. And Sharon Maweo, where's Sharon? There you are, next door to Pauline. Sharon is one of our other trustees. So do come and find us and talk to us about any new projects or ideas that you have. Right, so thank you very much for listening.
Thank you, Sally. And I believe she deserves a stronger clap. Thank you. And you realize she has the history of palliative care provision in this country. And if you've not heard about Hospice Care Kenya, Sally is here with the people she's just mentioned. And we need to talk to them, because if it's not had a direct impact on you, the activities of Hospice Care Kenya, I'm sure you'll get someone who has had an impact from the activities that are taken by that association. Thank you so much. Now, ladies and gentlemen, it's my honor to introduce a colleague and a friend who will speak to us next, David Kariuki. Dr. David Kariuki is the CEO and Registrar of the Kenya Medical Practitioners and Dentists Council, which is the regulatory body responsible for overseeing the training and practice of medical and dental professionals in healthcare institutions and community oral health officers in Kenya. Dr. Kariuki is a specialist in health systems policy and management with over 26 years of experience in the medical field. He has held various leadership positions, providing expertise in healthcare service delivery, development of health services operation systems, and strategic healthcare management. Previously, Dr. Kariuki was the Senior Deputy Director of Medical Services in charge of Department of Health Policy, Financing, and Research Development at the Ministry of Health. He has also served as the head of the Universal Health Coverage Coordination, head of Policy Planning and Health Financing, and the head of Health Sector Intergovernmental Affairs at the Ministry of Health. He has also demonstrated his ability to positively transform organizations while serving as the medical superintendent in Kehpca Level 5 Hospital. And thank you, Doctor, for introducing palliative care in Kehpca Level 5 Hospital. He has an MBA in health management from Strathmore University, a Master's of Medicine in Obstetrics and Gynecology, and a Bachelor's of Medicine and a Bachelor of Surgery from the University of Nairobi. He has also a postgraduate diploma in health systems management and is a member of the Kenya Obstetrics and Gynecology Society, Kenya Medical Association, and is a fellow of the East Central South Africa College of Obstetrics and Gynecology. He is credited with leading universal health coverage effort at the Ministry of Health, specifically the development of the first roadmap towards UHC under the Big Four government agenda. The benefit package included aspects of palliative care management for the first time. Dr. Kariuki's presentation, titled The Role of MPDC in Enhancing Palliative Care Provision in Kenya, will discuss the possibility of categorizing and registering palliative care centers, especially towards the attainment of UHC, minimum requirements for a center to be categorized, recognition of palliative care specialists, continuous professional development, among others. Karibu sana daktari.
Right. Good morning. As you've heard, well, a very kind introduction. I didn't know I have such a long. But happy to be here, to be able to share with you a bit about what we do. I know all the previous speakers have talked about service provision, but you know, as you provide services, we need to agree on some standards of care and what needs to be done at what time. And that is where regulation comes in. So we are part of the regulators of healthcare service delivery and service provision to wananchi. We do have a lot of information, scientific knowledge that we are supposed to use without causing any harm to the clients that we serve. So we as regulators exist to be able to assure public of their safety, as well as guide the professionals as they provide their services. That is what I am currently doing, at the Kenya Medical Practitioners and Dentists Council. But as a prelude to that, as has just been mentioned by my friend Weru, by the way, I first met Weru when I was a medical officer and he was one too, many years back, within the public sector in Kenya. We have personally been able to, advocate and make things for palliative care services to be done. Because without palliative care services, we cannot say we are having a continuum of care for any patient that we encounter. Our patients require to get the whole range of services that they require, from promotion, prevention, like was mentioned by, I think, Dr. Emmanuel, to end of life or terminal care, and that is still a very critical part. And whenever you find there is a gap, then you want to fill that gap. And that's why when I was at Kiambu Hospital, we made sure that that part of service delivery is also being provided, that we do not need to refer for some things that we can also do where we are. During the universal health coverage pilot, we made sure that part of the package of services included palliative care services. And I believe, like where we are today in Kisumu, when we had the UHC pilot, any patient who required palliative care services and they were available received them as part of the UHC pilot. And as Dr. Emmanuel said, that it is possible to put these things in the package and they be done and become implementable. The UHC pilot for that part proved that it is possible. So this country can be able to expand that, including palliative care services as part of the benefit package that will be paid for as part of universal health coverage becoming a reality, and ensuring that all our patients are able to access any services. Because UHC is about one, accessing services when they need them for their needs without financial hardship. And the pilot, as the word indicates, is a test, and a test is to show whether things can work or not work. So for that, we showed that it could work. So as a medical practitioners council, we are the regulator of health services in the country, given by law through what we call Cap 253 of the laws of Kenya, to regulate the training and the practice of medicine in the country. And we have also been given the mandate to regulate health facilities in Kenya. So in terms of practitioners, we regulate the doctors, dentists, and oral health officers. But more importantly, for palliative care, we regulate any health facility that is within our borders. And since palliative care services are provided within health facilities or as standalone or within health facilities, then we become important for you to be able to interact with us. And that's why we are here to briefly explain to you what we need for you to be able to either categorize or register a facility as a health provider for palliative care services. And beyond that, because if you are going to be recognized by the NHIF for purposes of payment for the services you have provided, then you require to show them a license of registration from the medical council. And because we have been able to do it for a while for government, we believe that even in the new reforms that are happening for social health care, KMPDC will still be the single or the source for licensing of health facilities for service delivery. And we are going to be able then to be able to categorize, services either as standalone palliative care services or palliative care services within existing facilities. We, as of now, I think have over 1,900 beds in this country categorized for palliative care services, which I think already receive or are empaneled by the National Hospital Insurance Fund. Now it's the National Health Insurance Fund transitioning again. Our philosophy is to become the best, a world-class health regulatory body to be able to be recognized across the world. Most of the things we do here are agreeable because they are standards across the world are accepted. We do our mandate, as I said, over health facilities, practitioners, medical and dental schools in terms of teaching, internship training centers, and collegiate training. I don't know if palliative care you have started fellowship training yet. If you do, we shall work together with you to ensure that we are increasing access to care by those who require it. As I said, we set standards for training, assessment, and registration. We also then follow up for purposes of ensuring there is compliance to the set standards. Once we register you at the point of registration, it means you have met the minimum agreed standard. But for continued service delivery, then you require, we require to inspect regularly to be able to ensure that one is providing services as agreed at the time of registration. We also do discipline and ethics, as we said, public safety. Sometimes the clients that we treat feel that they were not treated well enough, or they have questions that are not answered. We become the people between the provider and the client to be able to provide closure or solution to any questions that may have arisen. The client gets an opportunity to be answered all their questions. The provider gets an opportunity in an environment where they can now give answers truthfully, and we agree on whether there was merit in the question or not. If there was merit, we then agree on the best next steps. If there was no merit, we still assure the patient that the best was done for them, irrespective, despite maybe the outcomes that happened. I think I will not go through this because this is more details about what we actually do. When it comes to standards, we set the minimum entry requirements into a training program, minimum requirements for categorizing health facilities. We also regularly inspect the training schools and service delivery centers, and then our registration. And so for us to do our regulatory work, we then set a framework for professional standards for practice. We also set up mechanisms for evaluating those among us who may be impaired in terms of service delivery. So we have what we call fitness to practice mechanisms, so that if there are questions from colleagues or from patients, we can then help the practitioner to continue being a good practitioner as is expected. And we also do assessments for those who require to be registered under us. Those who may have trained from outside of our borders, we conduct either peer reviews or exams for them to be able to work locally. We also provide technical advice to the ministry and to any other stakeholders that may require our advice. We also set standards for scopes of practice in terms of recognizing who is a general practitioner, who is a specialist, in terms of service delivery for the medical practitioners. I'm happy to say that palliative medicine is one of the recognized specialties in this country under the Medical Practitioners and Dentists Council. So there's a lot that we are already doing for palliative care. If you reach a point and you want to have sub-specialists within the palliative care medicine, we are ready to work with you for that. but I think for the larger majority, is about the health facilities and how one can go about coming up with a palliative care center. There are many things that we look at. Currently, what we are using as a standard is some gazetted rules that were done in 2021 that provides a schedule of what is a level of service that is provided. And this is general, but if you specify it to palliative care, it would still be applicable. So the list of requirements includes what services are being offered, the infrastructure that is available, and the personnel available. So as the number of personnel increase and their skills increase, then the level of service delivery also increases in terms of the category that is provided. But remember, the ultimate is what will provide most benefit to the clients that we require the service. For example, client requiring palliative care services may at times get other medical conditions that may require treatment. For example, they get maybe obstruction for requiring a surgeon. So a center that will also have those other added services may be given a higher categorization. So what we check mostly is how the facility is managed, whether it has met the minimum requirements, the services that it proposes to provide, infrastructure and personnel, like we have already said, how they keep their records, and then we score using a checklist. If one passes, then we provide a registration certificate for the facility, and then an operating license. The operating license is an annual license running from 1st January to 31st December. That just shows you the process flow. Application, then we review, we come and inspect to confirm that it is an actual existing facility. We make a decision, we provide the certificate and issue it, and then continue operating. At the initial registration, we are a bit lenient, because if you say, we say if you get 50% of that checklist, we allow you as initial compliance. Then you can keep building up to 100, because we know you are starting. But below 50, we have partial compliance. You are allowed some time to make things right. But below 40, then we have to do a lot of work to be able to comply. So currently we have what we call level 1, which is the community health unit, we all know. Then we have level 2 facilities, which provide basic outpatient services. So the highest level skill here is more about consultation and minor treatment. So you can actually have a level 2 palliative care service, because it will be provided, it will be providing basic services that we shall have agreed on. Normally, when we come up with what you are seeing up there, we work with stakeholders. What we have agreed on is what we get into the laws. You can see, as examples, home-based care services are provided as level 2. So you can register a home-based care level 2 palliative care service. You can see eye clinic there. So there's no reason why we shouldn't one day put palliative care clinic, isn't it? And this is, as I said earlier, though we are medical practitioners and dentists council, is not doctors and dentists only. For you to open a facility, all you need is to be registered as a company, and then tell us who the health provider in charge of the facility will be. For level 2 and 3 services, it can be any health provider as in charge, because it's basic service provision. It could be a doctor, it could be a nurse, it could be a clinic officer, any other health provider. Sometimes even a businessman, but who is able to employ the right health providers. So don't be worried that medical practitioners, it's not for doctors and dentists only, it's only for their profession. But when it comes to health facilities, it is open to any health provider. So the services keep increasing. By the time you get to level 4, it is now an inpatient center. And I think we have a few hospices that probably are at level 4, and which are already empaneled by NHIF. And they have specialists. So beyond maybe just providing the palliative care services, if they require a physician, they will be available. If they require any other specialization for other related services beyond palliative, they will also be there. And we also have the level 5s that now have even the subspecialists, intensive care units and such. Level 6s basically are more providing teaching hospital services. So that's just a summary of the levels of care. So for us and the association here for palliative care, we can collaborate in very many ways. One, CPD, we are a CPD, we accredit CPD providers. And as you know, because there is a lot that is required for providing services, we tell our people to always keep updating themselves. For us to issue a license and require about 50 points to get their annual license. We can collaborate in curriculum development for any trainings that you may want recognized by the council, especially as we accredit facilities and even provide specialist and subspecialist recognitions in palliative care medicine. Facility recognition, we develop rules. For example, currently we have rules for mental health institutions. Now we have level 2, level 3, level 4, level 5 mental health institutions for being provided across the country. And for palliative care, we can work together, develop similar categorization rules, and we gazette them. And anyone then providing maintains that standard through the checklist that we develop. We have panels of experts at the council that help us to determine various issues, like when I said discipline and ethics, when I said we have, developing the categorization, we can ask you to be part of that journey. And I think with that, we shall be able to improve palliative care services across the country. Once we have provided you with our registration, then you apply to the NHIF to become empaneled and get paid for the services that you provide. And I think someone will be able to improve on that. With that, I may have maybe triggered you to ask a question. I'll be ready to answer. Thank you very much.
Thank you very much for keeping it short and very precise. Can we clap for him once more? Thank you. And now, having a regulatory body person in the house, we've known what we are supposed to do if we want to start our clinics, where to knock, and what is expected of us. Keep our questions, because after this, we'll have a panel for the question for all the presenters. Now, I have the pleasure to introduce to you our next speaker, who is Dr. Samson Kahora. He is a healthcare professional in Kenya with a post of graduate specialization in epidemiology, business management, and healthcare financing. His work experience includes donor-funded programs, medical insurance, including strategy and policy design and marketing analytics, medical product development, and return on investment modeling. Dr. Kahora heads the benefit design and claims management at the National Health Insurance Fund, where he has managed health reforms, reform agenda with the strategic procurement development being established in the World Bank, JLN, Nation Benefit Package Revision Guide 2023. Dr. Kahora's presentation this morning is entitled Financing the Palliative Care, Sustainability for Long-Term Care. He will discuss financing model to achieve equity and inclusive in palliative care, as well as the role of NIF in mitigating financial faced by patients needing chronic comprehensive care, most of who are in need of palliative care. And at this juncture, I will usher in the podium so that he can take us through palliative care financing so that we may know how best we can entitle our clients. Karibu.
Thank you. Good morning. I hope I look like the money I'm talking about. I'll take you through what we've done as far as palliative care is concerned. First of all, I would want to appreciate the association. We've been working closely over the last 2 years, and the main drive was to help us support what we are calling strategic procurement of healthcare services. It's been one of the key drives in the last few years for the fund, and it's one of the things that is meant to help the fund deliver on its mandate, which is being responsive and financing the needs of the population. So it's not about who lobbies, it's about what the population needs. So I will take you through what we've done so far, the transformation journey that has been there at the fund, the experiences, because the organization has been there for more than 60 years, and there are learning points that we have in terms of the challenges or the uniqueness of our operating environment. And then we'll take you through what we are considering to be sustainability as far as financing healthcare is concerned. And then I've mentioned that we've worked closely over the last 2 years. I'll take you through where we are as far as the discussions that we've had are concerned. So overall, this has been the transformation journey of the fund for the last 60 plus years. And the fund was basically established by a sessional paper in 1965. One of the key changes was in 1972, where any person residing in Kenya could be a member. So ideally, the discussion around universal health coverage ought to have started 51 years ago. But that's where we are now. In 2012, there was an expansion specifically to cover the medical schemes for government workers, and it started with civil servants. Then one key change that was there was towards sustainability and the UHC agenda that my colleague has mentioned. That was in between 2018 and 2020. Then in 2022, one of the barriers that we had as far as palliative care was concerned was mainly legal, because hospices were not recognized as healthcare providers. So that revision was made in January 2022. And at present, and aligned to the current government agenda, we have an agenda of leaving no one behind and achieving universal health coverage. So with this, I'll take you through the pillars. And then when it comes to the financing, the proposal or the legal provision now is to transition into a social health authority. So that's where we are at the moment. For the benefits specifically, I've mentioned that there has been a deliberate effort in the last 5 or so years to move or to make significant changes as far as what is financed in the country is concerned. So before 2018, it was largely informed by reviews and proposals that have been made by different individuals. But from 2018, there was a deliberate attempt to have actuarial analytics so that the decisions that are made by the fund are actually supported by data or evidence. And this was informed by several reports. In 2018, there was the Health Benefits Advisory Panel that was headed by Prof. Kokwaro and a number of specialists in the healthcare financing field, and they made recommendations as far as what the country needs is concerned. Then in 2019, there was the Health Financing Expert Panel report that was looking mainly at sustainability of the healthcare system. We are aware of reducing donor funding. We are aware of the current operating environment in terms of inflation, both market and medical inflation. We are aware of the significant out-of-pocket payment that is there for the population. It's estimated at about 26%. For the chronic diseases within NHIF data, the out-of-pocket payment, even for the members who are covered, is estimated at about 51%. So it's still a significant, the financing is still a significant barrier when it comes to access. Then we had an extensive internal review to basically look at the benefits, what has been the journey, how does it compare to other countries, and what is the way forward. So that is the extensive benefits review framework. And from this, we came up with a harmonized benefit package. And it's this paper that was published by the World Bank through the Joint Learning Network as a learning platform for other low and middle income countries on how they can reform their benefits. Now in 2020-2021, there was implementation of a framework that I'll take you through. And then currently there is a lot of legal, ICT, institutional reforms that are meant to support this framework. And presently what we are doing is basically to shift from what is presently there as the national cover into an essential benefit package. You've realized the first two presenters specifically talked about what is considered essential. So that's what we are moving to, so that we can finance what is considered essential as a priority. And I'll take you through that. So what are our lessons? This is utilization data for the last financial year. And from this, we can pick out that chronic diseases are likely to be a significant burden when it comes to financing, unless something is done about it. So if you look at the current proposals, there is a strong focus on primary healthcare. There is a significant investment. We are looking at about 7 billion shillings a year when it comes to screening, so that some of these cases can be detected early enough. And the reason for this is when we look at the data for cancers, a data set of about 25,300 cases, there are about 33% of that has been categorized in terms of the staging from stage 1 to stage 4 cancers. And of this 33%, 51% is stage 4. Now, the average cost of managing a stage 4 cancer is almost 6 times the average cost of managing cancers in general. So if that is the patient that is going to be presenting to the fund, then it becomes a significant barrier towards sustainable financing. And you can see the impact in terms of the chronic conditions. It's quite significant in terms of the average cost. When you look at it in terms of the lost revenues to the country, look at the average length of stay. That is the duration of admission. It's also quite long compared to the other diseases. So when you are looking at financing, we are not just looking at the disease itself, but also the loss to the economy by this person either being admitted or having to regularly visit the hospital. And that is what has informed some of the revisions, some of the key revisions that are being made now. This is another slide that meant to look at what are our challenges within the country. Now, I mentioned that in 1972, there was a move to open the contributions to the fund to the whole population. Now, one of the challenges that has been there is that the contribution has been voluntary. That means you can make a contribution, access a service, and exit immediately after that. So what this study meant to do was, what is the impact of having such a financing system? Because there is either the option of having it mandatory or having it voluntary. So we looked at these members who are making voluntary contributions. Now, the x-axis is basically the duration or the longevity in which they maintained active contributions. And the y-axis is the proportion of the services that they were accessing. Now, if you look at month 4, month 5, about 30% of the population that basically contributed for 4 to 5 months, 30% of them accessed maternity service. So you basically come into the fund, enroll, make a contribution of 2,000 shillings, make a utilization of 30,000 shillings, and exit immediately after that. I think that's good spot pesa for those who like gambling. So that presents a significant challenge because it drains the ability of the fund to expand the scope of cover. That's why there has been a significant drive, even within the current laws as they are, to make contributions mandatory. For the ones who can afford, they need to make that contributions. For the ones who cannot afford, then the government puts in initiatives for them to be able to pay for that population. For the ones who cannot afford the amount that has been recommended, then there be a subsidization program where they can contribute a percentage of what they can afford, and then the other is paid for by another partner. And for the ones who have seasonal income, because we have quite a lot of the population relying on seasonal income because of agriculture, the law currently provides for measures that can be able to do what is called premium financing. So a financier can come in, they pay their premiums for you, and then they recover it from you over time. And so far, we actually have contracts with 2 banks who are willing to do that. The other bit is that we've engaged the Kenya Tea Development Authority, and it has an enrollment of more than 1,800 farming households. So they are, as a SACCO, they pay the premiums, and then the members, they recover it from the seasonal income that these farmers get over time. So that way we are able to get over this income barrier that has been preventing us from expanding our scope of cover. Then the next bit I want you to look at, I hope that is gray. Some of us are supposed to be colorblind. If you look at month 36, about 28% of the population that maintain active contribution for 3 years are being treated for chronic conditions. That presents a problem because on average, the chronic condition is 5 to 7 times more expensive compared to any other average. So if that is the population that you are maintaining amongst the contributors, then it presents a challenge. And just to look at how significant this is, on average, a patient who is being managed for end-stage renal failure is spending more than 900,000 shillings a year. Their contribution is 6,000 shillings. So how many households does that member utilize? How many contributions per household does that member utilize? So if that is the financing status that remains, then it becomes difficult for the insurer to be able to offer the services that we are looking at. So if you look at the legal changes over the last 2-3 months, this has been the main focus, addressing the challenges that are there. The other is in terms of specialized services. Where are they being accessed? We all know that government providers are the majority in the country. And from the panel of providers, they form more than 70% of the contracted healthcare providers by the country. But when it comes to access, it is less than 26%. So that tells you that there is something that needs to be done about the government healthcare providers so that this investment that the government is making can actually be utilized to offer the service. Then I talked about value. At the end of the day, as a financier, we need to look at it from the value perspective. So this study basically looked at what is the return on investment. If you look at what the fund is spending as an investment, not as an expenditure, then what value does it add to the economy of the country? So this study looked at cardiovascular diseases as one of the conditions that are likely to be very common. Actually, they are the most common at the moment. And in the next 7 years, it's projected to be the highest killer in the country. So we use this as one of the diseases for return on investment modeling. And you can see on average is about 380% returns. So if you consider how much we are spending to how much we are saving by this person remaining at work, by this person working, contributing to the economy, then there is a return on investment that is 4 times what we are spending. So we are actually not spending, we are investing into the community. I think that message gets to finance and treasury. Now, this is what has been suggested, or rather this is what is being implemented as for sustainable financing. We need to have essential benefit packages. We need to have strategic procurement. We need to know where the resources are coming from, and we need to do monitoring and evaluation, especially for clinical quality. So this is what is being done at the moment. We know that we don't have adequate resources. Therefore, there has to be a prioritization. So the question is, what do we finance within the resources that are there? And I'll take you through that. So this is the way forward. One of the 12 criteria that we are considering is what is the government health sector priority. Because the political arm makes a significant difference when it comes to the financing. Now, with the current agenda by government, the beta agenda, health is one of the 5 pillars that are driving the government agenda. Therefore, there is quite a lot in terms of political support. The next question is, where is the financing coming from? Now, within that health sector priorities by government, there are 4 pillars. There is the issue of essential health products and technologies, so that should address the issue around medicines. There is the issue about human resources, so that should address the gaps when it comes to the human resource. There is the issue about health information systems and basically the adoption of technologies, because this is the only way we can be able to reach out to the whole population. And then there is a strong focus on healthcare financing. So this is what is expected to change. Historically, the fund has focused on the curative approach and the hospital-based care, but there is a move towards significantly putting in resources into preventive and promotive health. So that should address one of the concerns that has been raised. 2, there have been vertical services. So you'll find a donor-funded program that is financing one thing, and then healthcare financing as social insurance is doing the same thing. So that integration has not been there. But now we are looking at a comprehensive and integrated approach. And one of the support structures for this is the referral framework. So the issue of the levels of care and what the medical council is doing becomes very relevant as far as this is concerned. Then primary healthcare structures, they are mainly dictated by who is financing it. But at the moment, we are looking at having primary care networks that are fully integrated all the way to level 6s. So the referral framework comes in here. Then, as I've mentioned, the current model is not sustainable because of adverse selection, because of where members are accessing the services.
I work
because
with
of the
Kenya Flower Council.
So with this in mind, the sustainable healthcare financing model has changed, where the exchequer by law will be required to put in resources as government. So the fund is not going to be relying on contributions by members alone. The treasury is required to put in resources to be able to support that. And we've used the return on investment modeling to support why the government needs to put in the resources. Then there's also the ability to pay. If you look at the discussion now, it's around a percentage of your income being the contribution and not a specific amount. And this is based on the ability to pay concept, where the higher you earn or the more you earn, the more resources you put into the healthcare basket. So palliative care, we've discussed this, and this is one of the data sets that we've had with the association. Now, when it comes to the incidence of palliative care, because we have to look at what population is likely to need this service. From the data that we have, it is suggestive that cancer cases are likely to form 70% of these cases that require palliative care. Therefore, by extension, then morphine will need to be provided for within the essential benefit package. Then other chronic conditions are accounting for about 5%. And then pediatric terminal cases, that is pediatric palliative care, is going to account for about 25% of the costs when it comes to palliative care. The next question is, how much do we require to do that? Now, this is provisional data. I have to mention that. So from the provisional data, we'll require about 500 million shillings, and this is how the figures have been arrived at. Now, one of the key challenges that I would want to mention from this slide is that the capacity remains the biggest barrier, because from the data that is available from this association, about 3% of the population is likely to need this. From the projected admissions, it's about 1.3 million, but when it comes to the capacity to be able to handle those admissions, it's just about 1,825. So that becomes one of the significant financing barrier. We don't have areas where we can buy this service from. Then the next question is, how does it compare to the rest of the financing structure? It's been mentioned about psychosocial support. Therefore, there's a provision for mental and behavioral health financing. There's the drive towards medical devices, and I think that was a strong focus of discussion in a meeting in February. I met some of your colleagues there. So there's a provision for medical devices, and the allocation is about 2.7 billion. Then palliative care as a benefit by itself, as compared to how it is now, where it's aggregated with the medical admissions. So it's expected that palliative care admissions at an institutional level is going to cost about 547 million shillings. And then there are rehabilitative services, the speech therapy, the physiotherapy that this population is going to need. This plus the rest of the population is going to need about 9.4 billion shillings. So those are the percentages, those are the figures that you are presently working on. These figures are being refined based on what we are seeing, and that data should be available for public participation. We'll be hearing about public participation in the next 2 weeks. So thank you.
Thank you so much, Dr. Kohala. And I'm sure that we've listened and we've heard about financing for palliative care. And we all know that it's not enough, it's not adequate. All of us has a role to play. So in the next few minutes, I want us to have a Q&A for about 10-15 minutes. So I would want to request the panelists to come in front, and please, let's assist them. Okay. Any questions to the panelists? So please, you ask your question, say your name, and then ask your question. We'll pick about 3-4 questions, max, answer them, and then go to the next.
Good morning. My name is Rose White from Kehpca. My question goes to our panelist who has just come out of the podium. There is this private insurances whereby when you want to have an insurance for maybe your parent and some patients who have chronic illnesses, they restrict that if the person is above 70 years, they don't insure. And those are the people who need a lot of palliative support. And when you mention of chronic illnesses like cancer, still they decline. What is the way forward?
Okay. Thank you. Second question.
Thank you so much. My name is Mark Musiga. I come from Uganda, from the Palliative Care Association of Uganda. My question also goes to financing. There's this whole big question that we grapple with, and this is something you spoke about, but which I want you to elaborate, about the National Health Service and then a National Health Insurance. From where I come from, it's really a struggle. What would be the difference about the national service, and in the context of palliative care that really we know goes to the community and to the home? And then for Dr. Emmanuel, I wanted to just emphasize 2 points very quickly about the essential palliative care package that he spoke about. You know, at the conference in Kigali, and I know some of you were there at the Kehpca conference when the Kehpca launched the package, and this is available on their website. For countries, we're encouraged to go and adapt and make sure we have our essential palliative care packages for universal health coverage in our country. And as the Palliative Care Association of Uganda, we adopted that, and we even have it on our website. And it has helped us to do two things, which I thought I would mention. One, last year, the government accepted the Minister of Health, and we've had these discussions at lunchtime with some of the people. They have integrated fully the indicators for palliative care within the health management information system and the district health information system too, if you like to call it that. And so that answers the question, a big one that came out about the data. We hope, of course it's a long journey for Uganda, we still have to work on it, but at least we have had that. Now this year in April, the Ministry of Public Service still following that appeal, because the tool is very good. It gives you an opportunity to speak to policymakers in a very clear way. They have accepted, and the Public Service Ministry has integrated palliative care positions for specialists at the national referral hospitals, but most importantly, an assistant nursing officer position at all the health center 3s and all the health center 4s. Now for health center 3s, that's about 1,500 of them, and then health center 4s, that's about 222 of them. It's going to be a process for the government to recruit all these people, but it's going to answer a very big question for palliative care at primary health care level and UHC.
Thank you for that question. And Emmanuel, you'll answer that in the context of Africa and also bring it down to the context of Kenya. So please keep your question short. Maybe one sentence, max 1.5.
Thank you. My name is Edgar Lalet from Trans Nzoia County. I'm a medical social worker. My concern is we are putting more emphasis on integrating palliative care health management systems. There is still a problem on financing. Yes, the NHIF is the bills, but find that these patients pharmacies are empty, shelves are empty. So you are clearing the bill using NHIA, but you still have to go outside and purchase drugs. What are we doing to curb that issue?
Can we pick those questions and then go to others? And as the panelists answer and go to dealing with those questions, I think everybody has something to answer to. Can we start with Dr. Kuhora?
Thank you. I'll take up some of the questions raised. Yes, there's an issue in terms of private insurances and what they cover. Unfortunately, you have to appreciate that the objective of private insurances is different as compared to NHIF, because they are in it commercially. For us, we are in it to provide a service. So one of the ways of addressing the challenge that is there was actually to convert the fund into an entirely social insurer, so that it does not discriminate, if I may use your words, by age. It does not discriminate by diagnosis. It basically covers everybody, regardless of the condition or how much it costs. Now, to be able to achieve this, the approach is what I have described. One is to have as many people as possible enrolled. Of course, we know there are those who are going to be hard to reach. Therefore, we need to make a provision for that. Then for the ones who are in the formal sector, estimated to be about 2.7 million households. Reaching them will not be that big a problem because they have an employer. The ones who are in the informal sector, which is majority of the population, about 83%, then we've fragmented them further. There are those ones who are not able to pay entirely, not because they don't want to pay, but because they are basically considered to be food poor. Therefore, you will not pay for insurance when you cannot afford the food that you're supposed to be buying. So those are the ones who will be entitled to full government subsidies. There are those ones in the informal sector who are earners, but then their dynamics change. Either their income is low, therefore they will need partial subsidies, or they get seasonal income like the farmers. Therefore, you need to come up with a financing mechanism that supports them to be able to maintain active contributions. And that's where I mentioned premium financing. And then there are those ones who are elderly. We've had the Inua Jamii program, which was supporting the above 70. But then how do we take care of their healthcare? Because it is unique compared to the rest of the population. On average, from the healthcare finance data at NHIF, if you compare the average cost per patient for the population that is 16 years and compare that to the population that is 30 years, by the time you're 30 years, the average cost per member doubles. Then by the time you get to 62 years, it triples compared to 30 years. So we have to look at this aged population differently because their healthcare needs are also different. Have we looked at the numbers? Yes, there are about 270,000 households that will need direct support to be able to do that. So the approach is not to confront, not confrontational, but to have an alternative for this particular population. There was a question by Mark about primary healthcare. Now, I will explain the structures. How it's meant to work is that it looks at the whole patient care journey. And even when it comes to financing, we look at the whole patient care journey. I think the first explanation was pretty clear about anything that is under the skin from the time you're born to the time, and even after that. Yeah? So that's how we are looking at this member. So when it comes to the community level, there is what has been launched in the recent past, the community health promoters. So they're expected to offer some of the services, especially preventive and promotive health at the community level. And Dr. here mentioned about the role of the regulator when it comes to primary healthcare at the community level. Then there is primary healthcare at a facility level. So that is publicly financed. What we are looking at is publicly financed primary healthcare. Therefore, at level 2 and 3, most of these services are going to be government funded, just to make sure that there is a level of contribution by government. Then from that point, then there is where the social health insurance kicks in, largely in level 4 to 6, because that's where most of those complicated cases are managed. And then when a member exhausts their cover, because you have to look at it from a cover perspective. Are you able to finance the whole treatment plan? And if you're not able to finance the treatment plan, who takes care of the cost, the additional costs? At the moment, those costs are being met out of pocket. So that means, if I give a specific example, breast cancer management. On average, the out-of-pocket payment is about 61%. So even if the fund is taking up a liability of a significant liability, that's about 40% of the cost that you would have met, there's still a significant out-of-pocket payment. So for the ones who cannot afford, they have two options: either to start having these WhatsApp groups, kuchanga kidogo, or to specifically exit from care. Now that becomes a problem to their financial, because this person who was in stage 2, because we did not cover the whole treatment plan, they went out of treatment, they're going to present in stage 4 in advanced disease, and it's going to become more expensive. So that's where the critical and chronic illness fund that has been proposed by government kicks in, so that to make sure that at least the whole of that treatment plan is taken care of. And that is, if you look at the legal provisions, it's one of the provisions that have been provided for in law. Then there was a question about Trans Nzoia, and I will look at it from the pillars that I explained. When we're looking at universal healthcare coverage in the country, it's not just about healthcare financing. NHIF, or the Social Health Authority, has been proposed, is going to have its role in terms of healthcare financing. But then there's also a pillar in terms of commodity security. These health products and technologies, are they available in the country, and how much are they? And are they being provided to the patient? So that should address the issue of the medicines. There's also technology, and there's human resource, because it's a dynamic approach. Those 4 pillars have to be able to finance or to support universal healthcare. Thank you.
Thank you. Thank you, Dr. We go to Dr. Kariuki. As you answer your questions, in town B, let's say in Kisumu, we have a palliative care unit and we have a hospice nearby to each other. providing the same care, palliative care, to the populace. If you are to recognize, are you going to recognize both palliative care unit and the hospice? And if the palliative care unit is within the hospital, which is level 5, 6, or 4, will it be recognized as such? Will it be recognized on its own? And if the hospice is standalone, not within the institution, how do we work around the recognition of the service? Thank you.
Thank you very much for those questions. I think there was no question asked directly from the floor, but I see two that were written, and the third one from Professor Weru. I think one of the written questions asks, how many institutions in Kenya are training in palliative care? I would say that maybe in the formal training, we only have maybe the Kenya Medical Training College that trains especially nurses in a higher diploma in palliative care. For the postgraduate, in terms of doctors, I don't think we currently have. Most of our doctors have trained outside of our borders, but we do recognize that training. The current training is actually only within the KMTC that is formal. But we also know, maybe Dr. Zipora, there is a training, in order to improve access to palliative care services, there was, is it 6 weeks? Or a number of years, training that is provided to all healthcare providers to be able to start palliative care services within facilities. And this is where I say we can work together in terms of how do we recognize those trainings, so that as we categorize facilities, we also recognize if one has undertaken. We agree on what is the minimum requirement in terms of what does one need to have learned to be recognized as a palliative care provider for the level of service that they are providing, so that as we recognize that unit or hospice, then we say it is because it is being run by a skilled palliative care provider for that level. So each level will have, a minimum skill set that it can provide from the basic to the highest level that we could agree on. And I think the association would help us in that, being the ones who are more technically, in terms of knowledge, knowing what level of palliative care services can be provided. And I'm happy to have heard that there is, what was it called? The essential care package, because those are the things that we use to then determine what kind of services are provided at the various levels. I think the second question I go to is what Professor Wero asked. Yes, units that are close to one another can be recognized. And I think one of the issues that we are now moving towards is that previously we only used to recognize services and hospitals by level based on the minimums they had, especially in terms of infrastructure and equipment, and then maybe human resources. But we are now moving towards recognizing service availability rather than just the buildings, because we have realized that many people, as you saw, we are giving 50% first. Many people then go and reduce, especially on the human resource, meaning that you may be having a level 4 or 5, but does not eventually actually provide level 5 services. So we will now move in the future to service availability. So you can say you are having palliative care services, and that's why we are giving you a level 4. But at all times, or a level 5 for that matter, or whichever level, but at all times you must be able to be providing that service with a minimum requirement, especially availability of the required human resources. You may not have all the infrastructure in terms of the building, but if you have the human resource and the tools that they need, especially in terms of medicines and basic equipment, then we can be able to categorize those services. And I think even from the floor, the issue of health products and technologies is so key to service delivery in addition to the right human resources. So that's what we would do. So one of the advantages of having a standalone is that it will be recognized by itself at that level. And the reason that we now are moving to even recognizing units within existing facilities and giving them a level is because you may find even within an existing hospital, one of the units is so advanced that it probably providing level 5 services, but it is within a level 4 facility. And so that unit can be recognized by itself for such purposes, especially so because of financing, because it is providing higher level services, but in general where it is situated is in a lower level facility. Yet those services require to be compensated for the level of care that they are giving. That's why we are moving from not only just infrastructure-based to service-based categorization for units within. And we have done that, I think, even for bone marrow recently. We have a few facilities we have recognized for bone marrow transplants, renal transplants and such. And I think for this we can also take that route. Yeah, I think there was a last written question, which is not quite palliative care. But let me just mention, because it mentions that in Kenya we have many cadres of healthcare that are not regulated, and what are we doing about it? And I think it was passed to me because I'm a regulator. Maybe allow me because it has been raised. Yes, actually we have about, currently we have 43 cadres of health workers in this country, health-related professionals. But only about 11 are in formal regulation. So we have about 30 or 30-something cadres that are working with no regulation. And so maybe patients may suffer without. And so currently what government is doing has looked at the various options. One option is to form one overall regulator, because we cannot have 43, 44 regulators. You can imagine if you own a facility and all these regulators want to visit you once or twice a year. It might be that your planning is only about compliance. So we are saying, let us form one regulator. Looking at the challenges across the world, there are two options for that. The 11 that are existing can remain, and then form one more for any other who is not regulated. Option 2, we can look at in the existing who are more closely related and can be amalgamated, and then they are made one. And then if there will be those that cannot be amalgamated in any of them, then they can be put in one, maybe as allied health professionals for regulatory purposes. And it can happen. Just to give you as an example, our medical council has traditionally been for doctors and dentists. But from 2018, we added oral health officers, what you call cohorts. Yeah. Right now, I think dental technologists, theater technicians have also requested, and there is some request before Parliament for them to be added to our council. So you can see already our council has started accepting, because we believe it's an issue of multidisciplinary working. Yet everyone knows their scope. So regulating can be done under any of these. Thank you very much. Maybe that's what I would say for that. That says some work going around it. It will soon be sorted. Thank you.
Thank you. Sally, over to you.
Yeah, if I may, I just want to make a comment on health service funding. And the first thing to say is there is no perfect way of funding health services. It's all context-driven, what suits your particular country. In the UK, of course, the NHS is funded by taxation take from taxation, so you don't have to apply every year, which is very good in certain ways. But of course, at the cabinet level in government, health then competes with education, with housing, and with any number of other topics. And as you're probably aware, in the UK at the moment, the health service budget is not good, is not adequate, and there are many problems. And specifically on palliative care, although palliative care is within the NHS, you need to know that the hospices in the UK they're all charities as well, and about 30% of the funding for hospices comes from charitable donations. So it's not completely covered. So it's just worth knowing that. Now, to turn to a specific question that was written, I'm asked, are you able to fund 2 projects in one institution or county? And the answer to that is, well, it all depends. If we got 2 very similar projects from the same institution, we might say, hey, where's the joined up management here? And might challenge that. But if there were 2 really novel projects from one county, yes, each one would be considered on its merits. So please, make your applications.
Thank you. Thank you for that. And as Emmanuel, you answer your questions. What is this miracle you did? You mentioned Uganda. You know, Uganda is supposed to be in the 9th province of Kenya. Yeah? What miracle did you use to make sure that nurses are allowed to prescribe morphine in Uganda? Something I think should be universal in the provision of palliative care.
Thank you very much for that question, and thank you to the others who have asked questions and made comments. Let me begin this answer from a generic point of view. If we are saying we are going to integrate palliative care within the PHC setting, who are the professionals who work there? The backbone of the primary health care service delivery and nurses plus other professionals. Okay, you have doctors, but they will not have the same time. You don't have the same numbers of doctors, and they are not set up in a way to do it the way nurses do it. And so it becomes important to relook at who prescribes. Before I come back to Uganda, let me start in Zimbabwe. Last year, we supported the Ministry of Health in Zimbabwe to write their national prescribing guidelines for nurses in the PHC and other levels. They have also come to the same conclusion that Uganda came to, that if we are saying we want patients to receive the services where they are at with the least out-of-pocket costs, then you cannot tell somebody with stage 4 cancer that get into a vehicle, drive from, what is the remotest part of Kenya? Okay. Somebody said Lake Turkana. Maybe that will change with the discovery of oil and a few other things. But then you put him in a car and he drives 70 kilometers to just go and get a prescription of oral liquid morphine. That's where it becomes very important that we look for a way of delegating some of those roles to the nurses and midwives. And after all, the midwives are already using opioids, isn't it? Without even consulting doctors. They know when they should give, and they do. So what Uganda did, just like Zimbabwe has just done, was for the minister to design a statutory instrument. That statutory instrument stated the cadres that were not doctors or vets, because in most countries it's either the doctor, the medical doctor, or the vet doctor who prescribe opioids. Yeah, one doctor for his patients and another for both patients and food. Yeah? The doctor, because they eat their patients. Yeah, we don't. And a vet, if there is a vet here, please don't shoot me. But so Uganda wrote a statutory instrument. It stated the cadres, the nurses, the clinical officers, and they even specified the type of morphine that these nurses and clinical officers were supposed to prescribe. So it was a very empowering document for the nurses. And so as we move towards integration of palliative care within the PHC context, in the spirit of universal health coverage, it becomes important that we empower the people who provide the services at that grassroots, and the nurses come in handy. Sincerely, for a nurse who has undergone, and after all, whom do the patients spend most time with? It's the nurse. You as a doctor, you walk in, ask a few questions, say do this, and you walk away. And the nurse has been with this patient for all. And we lose nothing as doctors when the nurses prescribe something and prescribe it well. If you go to most hospitals, you'll discover that the custodians, even of these medicines, are either pharmacists, pharmacy technicians, or nurses. It's not us doctors. The keys of those opioid cupboards are not kept by doctors. They're kept by nurses. So what are we so scared about? Let's equip them. Let's equip them and even make it cheaper for our colleague in NHIF, because then you have a person. I mean, as long as we have guidelines, you have a person who needs opioids. He's in Clinic X or lives near Clinic X, and then the nurse at Clinic X, who is accredited to prescribe those medicines, knows when to prescribe and how much to prescribe. And then we also alert the other authorities that enforce controlled medicines regulations, like the narcotics police, so that they are aware that when they find these nurses who are doing home-based care and they are going with morphine, they are not taken to jail, because they have a statutory instrument that allows them to do so. Yeah, so I think I can stop there. Thank you very much.
Thank you, Emmanuel, and thank you, panelists. Let's clap for them again. And I know they'll be with us. There are so many questions, and David has the list. There are also questions from online, so we're going to share them with the panelists. We also have what we call the Intercounty Forum, Palliative Care Forum, that we will be able to respond to those questions. So, asanteni sana. Before you leave, it's the Kenyan way that we have to say thank you. We know how to clap in about 26 ways. But we also know how to say asanteni sana. So I want to welcome Dr. Zippy to now give our panelists gift before we go for tea, and they will be with us.
Good morning, everyone. I'm so delighted. Today, actually, I was telling Maculan, I'm seeing so many new faces. That means we are reaching people, isn't it? I was tired of seeing the same faces like me, but I'm seeing so many young people, and I'm so delighted that we have many people who are now recognizing palliative care. I came from Senegal last week. We had the AOTIC conference, and let me tell you, Kenyans, our new, younger oncologists are preaching palliative care. So work closely with them. I want to really add on what Dr. Weru has said, my colleague, also my younger colleague. I want to say thank you very much. It has been really enlightening to listen to all of you. Dr. Kariuki, I remember we developed a training content for medical students, undergraduate, when we included palliative care into the core curriculum in 2013, but they're not being trained. University of Nairobi is not training them. They always tell me we are never trained, and we actually paid a lot of money for that content. So please follow it up with Dr. Weru and his team. And thank you very much, Dr. Kora. We've always been on the other side of the table with each other in terms of NHIF. So I'm glad that palliative care is really being put on the table in our UHC package. Sally, you're a long-term friend. Thank you so much for continuing to support our initiatives, especially reaching to the very smaller palliative care service providers and considering them for your funding. Dr. Emmanuel, we've been together for many years. We are still together. I sit on the APCA board right now. I was on the interim board when you're starting the association. So, and you've really done a lot of support for us in Kenya. You're the type of person I'll call anytime. Maculan will call anytime. So thank you very much for being very open to our calls at any time. I really want to say thank you. Thank you very much for honoring us. You had to travel, leave your jobs. Others have crossed seas and oceans to come to Kenya. We thank you for all that. Maybe we'll keep the presents. It's sat anywhere. Just sat anywhere. So, Daktari, thank you very much. Thank you, Sana. Thank you. And please, let us implement what we talked about. Yes. Yeah, thank you. Daktari, thank you very much. Yeah. We hope to continue our conversation. Thank you very much. Yeah. Thank you. Yeah. It's the first time you're having somebody from KMPDC, so there's passion here. We invited them to the meeting we had on nurses prescribing, and they didn't come that time, many years ago. And I can actually say something about that. Kehpca has been working hard on that, on nurses prescribing. The biggest barriers to nurses prescribing are our doctors. They even refused to come to the meeting. They boycotted the meeting. Yeah, so doctors, please, let your nurses prescribe. I learned how to prescribe morphine from a nurse, not a doctor. Let your nurses prescribe, please. Thank you. Thank you. Sally, I'll give you a hug. You're allowed to hug ladies. You might hug a man and somebody says, what were you doing? Thank you very much. Thank you so much. Sally, she has been with us from the very beginning. She's actually a Kenyan by heart. Thank you very much, and your team also. Dr. Emmanuel, asante sana. Thank you very much, yeah. Yes, yeah. And we know that we can always call on you. You're next door. Thank you. Thank you very much, all of you, and come to every conference with better news every time. Thank you. Oh, we have to take a photo of you. Where is there? Where is you? You're also you and Dr. Where?
Okay. Thank you very much for our active participation. And now I'll request that we give ourselves a loud hand of applause. That was good. Now we'll break for our tea break. And it is the same place we had our tea yesterday, next to the pool. And we'll be back in the room at 11 a.m. So let's have a quick tea break, and then we proceed to our next session. And the next session will be very good, so let us keep time. We prayed in the morning, and the prayer covered everything today. So we can just go and have our tea. Enjoy your tea.